Many thanks to everyone who has joined us here this evening for the initial engagement and launch of the new community ophthalmology service across North Central London. My name is Owen Tom. I'm the provider relationship manager for Evolutio. We appreciate you've taken time out of your evening today to learn more about this service. The purpose of this evening is just to provide you with an overview of the new service and how you can actually get involved with delivering NHS funded care to your patients. Just for your information, this event is being recorded and it will be made available to view offline. The evening itself is going to be in three key parts. There's going to be an introduction from Delia O'Rourke, who is the Head of Plan Care and Commissioning at North Central London CCG. Delia is going to actually give you an overview of the service from a commissioning perspective. Following this introduction from Delia, we're going to be running a short demonstration video of the IT platform used that's going to be used to deliver the service. For those of you that are already involved with the NHS XEERS service, the look of this software will be quite familiar, and the platform can be assessed via your current NHSX logging details. The next part, Christian Dutton is going to be providing a clinical overview of the commission pathways. These will include the pre and post-operative cataract assessments, glaucoma repeat readings, and medical retina. This is going to be CET accredited. Finally, finishing off the evening, we're going to be having a question and answer session, all of which will be circulated to the attendees after the event. We do have a large number of attendees this evening, so everyone will be on mute. All questions raised and answered will be via the chat function. So please feel free to ask any questions throughout the evening, and our NHS service lead, Dougie Mason, will do his best to answer these. I would now like to introduce Delia.
Hello and good evening. My name is Delia O'Rourke. I think I've just been promoted by Owen. I'm Head of Planned Care for Haringey and Islington, but I'm taking a lead on ophthalmology commissioning across NCL. If we just go to the next slide, please. So a little bit of background about why we're here and why we are commissioning this contract. NCL CCG was originally 5 different CCGs, Haringey, Islington, Camden, Enfield and Barnet. Those organisations merged in 2022, which was terrible timing because that was the same time as we had COVID. But prior to that, because all the CCGs had worked separately but largely collaboratively, we did have a variety of services that have been developed and commissioned over the years. So, for example, our MEX contracts, we have MEX contracts in only 3 of the 5 boroughs across NCL, and even those contracts are different. They have different specifications and they have different prices. Pre-COVID, we had been working collaboratively with our secondary care clinical teams and operational teams, your local optical committee representatives, LOCSU, and myself and other commissioners. We had been looking to develop cataract, glaucoma and medical retina pathways to be delivered right across NCL. So there would be a single standard offer for patients that came through optometry-led pathways. Just prior to COVID, we'd developed a business case, but COVID intervened and we couldn't get the funding agreed. And that was partly because there'd been a change to the funding regime across the NHS. Can we go to the next slide, please? So the impact of COVID. Obviously, services were reduced at the onset of COVID. We've had an increase in the number of people waiting for outpatient services, diagnostics and surgery. At the moment, we have just over 11,500 people who are waiting for care in ophthalmology services across NCL. That number is starting to decrease, but it's significantly higher than it was even in March this year, when there were just over 8,000 people waiting. Obviously, there are more people waiting for surgery as the numbers have gone up, but there has been a great deal of work done by providers to reduce the number of people who've had excessively long waits, particularly over 1 year waiting for surgery. And at the moment, we've got under 400 people waiting over a year, and a significant proportion are people who have chosen to delay surgery because they don't feel safe coming into a hospital environment during a time of COVID. So there are lots of actions in place across NCL to reduce the number of patients on waiting lists and to manage those waiting lists effectively. So the first one is trying to work through how we can reduce the flow of inappropriate referrals or clinically unnecessary referrals to secondary care. And that's about how we can manage patients better in the community. And that's why I'm here today. Second is we have demand management, which means that we are flagging to referrers which services or which subspecialties are particularly pressured at our local trusts. And part of that is also offering patients alternative locations to have their care if they are likely to wait a long time. We've got work going on with our secondary care colleagues to improve the triage of referrals that they receive. We've had a significant increase in the number of outpatient appointments that are being provided, and we also have a new diagnostic hub which is increasing our diagnostic capacity for North Central London. Our acute providers are increasingly using video and telephone appointments to again manage capacity. Mutual aid means that the hospitals are working collaboratively and offering patients the choice of moving to a different hospital if they could have their surgery done quicker. And we've also got some high volume surgical hubs running to increase our theatre productivity. Somebody's asking where the diagnostic hub is. That's at Finchley Memorial Hospital. That's our first diagnostic hub. It's got a number of different specialties running there, including MRIs and CT scans, as well as ophthalmology. And there are plans to have a second diagnostic hub opening at Wood Green Shopping Centre, but that will be next financial year. Patients are, there's a new scheme that's being offered for some patients, which is patient-initiated follow-up, which means that patients will have a choice of when they come back to hospital for follow-up arrangements. That's particularly being used for gastroenterology, but there will be an offer available for some patients with ophthalmology conditions. And then finally, streamlining discharge processes and discharging patients when it's clinically appropriate, rather than patients coming back for repeat follow-ups if there's no clinical value. So these actions are in place across a number of clinical specialties, and all of these are happening with phlebotomy, with ophthalmology services. Can we go to the next slide, please? Right. So to manage elective recovery and to try and get waiting lists down, there's been a fund which is a pooled resource of monies from all of our acute trusts, which is being used for a series of initiatives and pilots across NCL, multiple specialties, primary care, secondary care, and in acute. We've managed to secure some of that funding to commission optometrist-led pathways for cataract, glaucoma, and medical retina. Because of the value of the service, we were required to go through a very short procurement exercise, and Evolutio have won the bid to run this service. It's a proof of concept. We have to demonstrate impact over a 6-month period. So it's really important to get this project up and running and to demonstrate that there's been benefit. So if we think about what was on the previous page and actions to manage referrals, the 3 areas which are really important for this are reduce the inflow of patients who could be managed in the community, and that includes improved triage of patients at optical practices, but also by our secondary care clinicians. And the more information our secondary care clinicians have, the better able they are to decide what's the appropriate management for patients with minimal further investigations, if those investigations could be done in primary care. And also improving discharge processes. So we're looking at having discharge of low complexity cataract patients back to optometrists. By having that facility, it does mean that that releases outpatient appointments, which means that more people can have their first appointment in secondary care, and that allows also the services to risk stratify patients and decide who needs to come back, who can be discharged, and who needs to go for surgery. So the tangible benefits we're expecting to be able to measure from this project are a noticeable reduction in the number of referrals across the 3 pathways that have been targeted. The number reducing or having an influence on reducing the number of people on waiting lists and bringing waiting times down as we reduce the number of referrals into secondary care. Increasing the surgical conversion rate for cataract patients, and that means a higher percentage of patients who are referred to secondary care will go on to have surgery. There's always a bit of a drop-off of patients who, once they get to secondary care, decide that they don't actually want cataract surgery or they want it deferred. It's far better if that's identified at an earlier point in their clinical pathway. We also want to demonstrate that the service is safe and also that it's cost effective. That's the end of my presentation.
Many thanks for that, Delia, and for joining us this evening. Next on the agenda, we now will play a pre-recorded demo video for the software to show you how and to add a patient to the community appointment.
Welcome to the Evernecht EOS web app demo. First of all, we're going to log in using a username that you've already been assigned. If you want to know how to get a username, please refer to our help video on how to get your username set up. So let's log in. First thing we're going to do is choose which clinic we're working at today. And then onto the home screen. You'll recognise this from the GOS18 app. And we're going to pick consultations. We've got 2 home buttons. We're going to choose add a new consult. Let's search for our patient. Searching for less will give you more results. If you put in a long name, then obviously you're at risk of a typo. And here we've got our list of results. We're going to pick our patient and view that patient. We've got 2 options, do a cataract post-op report or an EOS visit. We're going to do a cataract post-op report to start with. Here's the post-op form. We're going to put in the date of the procedure, the consultant's name and address. The address will be replaced by a drop down of the local integrated hospitals within the EERS project. And then we're going to work our way down this form it's a paper form you'll probably recognise. Which eye was treated, method for intraocular pressure, IOP readings. Anything with a red asterisk is a compulsory field. And then the rest is radio buttons, which is quite quick. You can do this on an iPad if you wish, which would be quite fast as well. Let's just pick some random buttons. Okay, onto the data entry section. You can see visual acuity is the only compulsory field, but you might want to put in the RX and unaided VAs. I've got an additional comments box there you can populate as you wish, and then the patient's satisfaction, and then visual outcome, and then you hit submit, and that will submit it through and onto the hospital, and that's the end of your process. We can now go back and add a enhanced service visit. We'll walk through that journey next. Okay, so you've got your home burger button at the side, which reflects the same as the buttons in the middle of the screen, but some people prefer a menu. So add consultation. We're going to put in our patient name again. Pick our patient from the list and then view that patient. Okay, this time we're going to do an EOS visit. Okay, so this is our full ophthalmology record. As the service develops with the local stakeholders, we may modify and reduce this form, but for now we're using this full ophthalmology visit. Again, the red asterisks are compulsory sections on the form. You can shrink each section of the form if you wish, and you can also use the abandon selection there just to clear a section you're not happy with. Being radio buttons, it is quite quick to work down clicking, but it's broken up into sections as you'd expect with any normal ophthalmology record. And then there's drop downs to key parts that were more appropriate that way. And then we get to our conclusion, where you're going to put in your impression and proposed care plan and any medication you choose to dispense, and then submit as before. Okay, so now we'll just show you how to add a new patient. So if we search for somebody, we get a list of matches. If we can't find the match we want there, then we choose add new patient, and that presents a new patient form. And we put in the relevant contact details. There's nothing unusual here, and the GP lookup at the end. That's the same as the GOS18 referral process of adding a new patient. We can also go into recent submissions and see any previous submissions for that patient, the patient that we've got highlighted at the moment. Reopen that form, and we could say print a copy of that if we needed to, but for audit purposes it's useful to be able to go back in and see what previous visits you've done.
Okay, so now we've heard from the CCG to see and seen how to use the software. Christian Dutton, our education and compliance lead, will now provide an overview of the clinical pathways that have been commissioned for this part of the service.
Thanks, Owen. Yes, good evening, everybody. And just to echo what Owen was saying, thank you very much for taking the time out this evening to join us to learn more about the Community Eye Service, which has been commissioned in North Central London. It's a really exciting service, which, as Delia was saying, is joining up a series of smaller geographic areas to give a much more unified service, ultimately for the benefit of your patients. As Owen said, I'm the Education and Compliance Lead Optometrist for Evolutio. And my brief really for this evening is to run through these pathways with you, I suppose partly from a sort of operational perspective, but also from the perspective of a clinician, so that I'm hoping it will just give you a flavour for what it's like actually seeing one of these patients within the service on these various pathways. So first of all, let's have a look at the 4 pathways which have been commissioned. We have cataract pre-op and cataract post-op. We have glaucoma repeat readings, which kind of subdivides into IOP and visual fields. And then we have medical retina, which is quite specifically looking at wet AMD and diabetic macular edema. The service, or the people who are eligible for these pathways, for this service, are those with patients who have a registered GP which falls within NCL, or a patient living in NCL who doesn't have a registered GP. And I think that latter point is quite helpful, because we often find patients who don't have a registered GP, or the GP is registered elsewhere. So this just gives these patients who don't have a registered GP access to the service, because ultimately they still need to be seen. Delia's already touched on this, so I won't cover old ground, but a 6-month contract with an evaluation and a short time period to mobilize the service. So just to thank you really for bearing with us at short notice for this evening's presentation and the mobilization of the service generally. So let's kick off with cataract pre-op. When we hear the term pre-op, we think about things like biometry and things that the hospital would be doing before the patient goes under the knife. So this is not a true pre-surgical assessment. This is really a way of establishing whether or not, if a patient goes forward for surgery, they're likely to end up actually having surgery off the back of that. So there's a few things that we look at here. First of all, does the patient actually meet the CCG criteria for NHS-funded surgery? And we'll have a look at that in just a moment. Does the patient understand the risks and benefits associated with having cataract surgery? So are they making an informed choice? Does the patient even want surgery? So that, for a surgeon, must be very frustrating for the patient to actually be sat in front of them, to be eligible for surgery, for the consultant to then offer them surgery, and then for the patient to say, well, thanks, but no thanks. And what a dreadful waste of resources that is. So what we're really doing here is trying to tease out what's essentially a false positive referral, not necessarily on clinical grounds, but also from the patient's greater understanding and informed decision-making. And is the patient clinically suitable for surgery? Is the patient going to struggle to lie down? Are they claustrophobic? Might they need a general anaesthetic? Are they frail? And a lot of what I'm saying actually comes from NICE NG77, the cataracts in adults management guidelines, which was a real game changer, I think, for optometry and for ophthalmology patients, where we've made, quite a strong move away from, for example, a visual acuity of 612 being the be-all and end-all of whether or not a patient was entitled to have surgery on their cataracts. And we're now looking much more holistically at the patient. So the patient as a whole, a patient, say, who's a watchmaker or a microsurgeon with a VA of 6, 7.5, may well find that their quality of life is affected to such an extent that they really should go ahead and have that cataract surgery done. So to be able to consider quality of life, I think is extremely important. And if we just turn to the NCL cataract policy over here, I've just highlighted the key part. So we're talking about a best corrected acuity of 6/9 or worse in the first or the second eye, which is actually quite generous. A lot of CCGs are 6/12, some are even 6/18. So I think this is really good. And the patient has an impairment in their lifestyle. So it's affecting their activities of daily living and their leisure activities, their work, a risk of falls. And I'll give you some ideas around what activities of daily living might look like on the next slide. But I think this word "and" is really important. So as we all know, a patient could have a VA of 612 or 618 and be totally happy. No, it's not affecting my day-to-day living. You know, I'm not a driver, for example, in which case they're not going to meet the criteria. So just remember that in the context of this pre-op pathway, there needs to be an effect on their quality of life, a significant effect. So all of the 4 pathways I'm going to talk about this evening sit at core competency for optometrists. So as long as you have the necessary equipment, then you'll be pleased to know that you'll be able to deliver these pathways to your patients. Now, some of us would feel that we require some additional support or training, and there are resources available to support you with that. So for example, the WOPEC Cataract LOXU course, or indeed, if required, we can provide training on pre-op assessments for you. And all of this is underpinned by a clinical protocol, which I'll show you in a moment, which literally walks you through step by step what you need to do. A bit like in the video we just watched for the post-op assessment, where it's essentially giving you the questions to ask and the data fields that you need to populate. From an equipment point of view, I'm going to talk in all 4 of these pathways about quality in optometry level 1, the contractor checklist. It's section B24 if you want to have a look at it, and it talks about the clinical testing equipment that you require to deliver GOS site tests. The equipment has to be in good working order, of course. And to deliver this pathway, you don't need any additional equipment to what you'd require to deliver a GOS site test. The process for this is that the patient either walks in to your practice, or you do a site test and you discover off the back of that they have cataract, and you then refer the patient to yourself to then complete the cataract pre-op assessment. There are a series of standardized forms which are built into the web app. And today you've seen 2 of those, the sort of generic enhanced services form, as well as the cataract post-op form. But in due course, you'll also see the pre-op form. And as you can see, as the video demonstrated, in order to access the web app, you use your existing login for the NHSX service. So for those of you who are delivering that, you're good to go. For those of you who are not currently delivering that, you'll need to sign up for that. And I'll show you that towards the end. This is the clinical protocol for the cataract pre-op assessment. And in fact, the version of this that you'll be shown is slightly different to this, but it's 90+% the same. This is from our larger handbook. So it literally walks you through step by step for history and symptoms, the questions to ask, the initial test to undertake, the parts of the anterior segment of the eye to look at, posterior segment. And then you'll see here this sort of 1-pager, which actually is the pre-op assessment in paper form, which will then appear within that web app with the radio buttons, as Peter was showing earlier. We'll have a look at this form now in a bit more detail. So the first section is the patient's name, address, date of birth, etc. And that will already be on the system, and it will be populated on the form for you. So you don't need to type this information in again and again. If we then have a look at the first section here, which is titled Clinical Details, I've called it here the core investigations. We start off with a refraction and visual acuity for obvious reasons. We measure the intraocular pressure and we ask relevant questions. For example, is there a history of refractive surgery? We then have a look at the back of the eye to look for any comorbidities. So the commonest ones, macular degeneration, amblyopia. Corneal opacities are quite interesting. Things like Arcus, for example, actually makes it quite difficult for the surgeon intraoperatively to see exactly what they're doing. A thick Arcus can be problematic. And in terms of dilation, you'll see there it says dilate where indicated. So if you've got a good view of the fundus and the level of cataract reflects well in the visual acuity, so you're confident that you've seen what you need to see and you can make a sensible clinical decision, then arguably a dilation wouldn't be indicated. If maybe the cataract's a bit more dense or the pupil's small, you're struggling to get a good look at the macula, and you really need to work out, are there comorbidities there that I'm maybe not aware of? Then you're really going to have to dilate that patient so that you can make an informed decision as to whether or not they should be going on for surgery. We're then on to this additional relevant information box. And there's no sort of hard and fast rules for what goes in there, but I'll just give you a few sort of clinical pearls or clinical pointers, which you may already be familiar with. The first one is pseudoexfoliation. And you can see here in the center, this pseudoexfoliative material, and just beyond what would be the margin of an undilated pupil, more of it. And this material deposits on the lens zonules. It weakens them. And you can imagine then that if some of the zonules start to break during cataract surgery, then the lens is going to come out of place and it creates all sorts of complications for the surgeon. So pseudoexfoliation and pseudoexfoliative glaucoma who require cataract surgery are normally done by experienced cataract surgeons. The next one is Fuchs endothelial dystrophy, and we've all seen that in the journals that Fuchs can decompensate following cataract surgery. So it's important to note that. Some patients' pupils don't dilate well. And what you can see here are actually 4 so-called iris hooks. So each of these is a little, essentially like a nylon sort of metal wire, which is hooked over the edge of the iris. And these red things are like little ratchets. And when the surgeon pulls this through, it sort of ratchets into place. And you can see it's physically pulling the pupil open, pulling the iris open so that the surgeon has enough access to be able to do the cataract surgery. And finally, medication. As you're probably aware, tamsulosin can relax the iris dilator muscle, so it's more difficult to get a good dilation in those patients intraoperatively. Excuse me. So moving on from there, we then have a series of tick boxes, and they cover several different things. The first one is to confirm indeed there is cataract present, and we think that the cataract is the main cause of the reduced VA. And we all know some of those cases where there's cataract and AMD, and you know that they're both contributing to the reduced VA, but it's a question of, which is the biggest problem. And there will be some of those where you have to make a judgment call. Does the patient want surgery? We've already talked about that. And I did say that I'd give you some ideas of things where different factors are affecting the patient's quality of life. So risk of falls we touched on, driving, ability to work, hobbies and leisure activities and social functions, glare and dazzle, and that could be during the day or the night, anisometropia, and if there's anything else which is relevant, and that's the place to put it. So, for example, the watchmaker example I gave you, or the microsurgeon who's really got a greater need for really good acuity than perhaps a similar patient with a similar level of visual acuity, but they don't have those same requirements and demands on their visual system. Do they smoke? If so, it's good practice to advise them to contact a smoking cessation service. You'll find that pharmacists can help with that, the GP can help with that. Of course, you can't force them to stop smoking, but it's good practice to refer them, even verbally, to a smoking cessation service. Because as you know, smoking is probably at least one of the causes of the cataract. We talked about awareness of the risks and benefits. We're not expected to understand the risks and benefits in the sort of detail that an ophthalmologist would, but as you know, we have booklets on cataracts that we can hand to patients. We can highlight the key areas and the key risks and benefits to the patient. It's important for them to understand that just because you are referring them on and they appear to meet the criteria, it doesn't mean they're 100% certainly going to be accepted for surgery. We're referring them on for consideration of surgery, which will ultimately be at the consultant's discretion. And some patients do benefit from a cooling off period. So especially those patients where it's a borderline decision, you may find if you say to the patient, have a think about it, I'll put this on hold for you for a week, have a think about your decision and let me know. And that, I think, again, will help to tease out those patients who are particularly keen on surgery versus those who are willing to wait maybe another year or whatever it may be. So that really concludes the section on the cataract pre-op pathway. And I hope you'll agree that that's all straightforward, that you'll be used to asking those sort of questions and undertaking those sorts of investigations on your patients already. So let's move on now to cataract post-op, excuse me. So we know that the NHS is under a lot of pressure, more so than probably at any time, certainly in a good number of years. And that extends to ophthalmology. It also extends to us as optometrists on the high street. But I think what we're really getting at here is patients who are under the hospital's care really should be those patients who require that level of specialist assessment, intervention, review, opinion. So do these patients really need to be followed up by a highly experienced consultant or a senior doctor? Or is that something that we as optometrists could take on and leave the hospital to deal with those more complicated cases? And I think that's really what the post-op pathway is about. Now, there's some patients who 100% certainly should be remaining under the hospital's care following surgery. The obvious one is the complicated cases. I don't know, say for example, somebody had the pseudoexfoliation, there were some problems with the lens on or some intraoperative or perioperative complication. They stay under the care of the hospital. There's no expectation that you would have to see that sort of patient within this pathway in the community. The other cohort of patients, which we sometimes don't think about, is the surgical trainees. So, maybe they're doing their first 20 or 50 cataract cases. And those surgical trainees, it's very helpful for them to be able to do follow-ups on their own patients so that they can see what the post-operative outcomes are like, and that can then feed into their learning and development. So some cases, even if they're straightforward, will be retained in the hospital for that reason. So for post-op, we're looking at three things. The first one is to make sure that the surgical outcomes have been met. So that could be in terms of the expected visual acuity. It could be in terms of the refractive target. It could be in terms of the effect it's having on the patient's quality of life. The second thing is to give some feedback to the surgeon who undertook the surgery. So this essentially is a type of audit. And with all the cataract post-ops, we send an audit report back to the treating surgeon. It's unlikely to be read by the surgeon. That's something that's usually more for statistical purposes. But still, without giving a surgeon feedback, or putting it a different way, by giving the surgeon feedback, that data is very helpful for them. And finally, if we do identify a problem post-operatively, things like cystoid macular edema, or if the cornea is decompensating, or a steroid response, for example, then we can signpost those patients to the most appropriate care provider on the most appropriate pathway. So those are the three objectives with the post-op pathway. Once again, this is a core competency pathway for optometrists. But as before with the pre-op pathway, for our colleagues who feel that they need a bit more training and support in this way, there are resources available to you. The WOPEC Cataract LOXU I already mentioned covers pre and post-op, and Evolutio can provide training if you feel that you require it. As before, all of this is underpinned by a clinic, and we'll have a look at that in just a moment. Equipment-wise for this particular pathway, as before, you don't need any fancy equipment beyond what you'd use for Gauss-Sight test as part of the Quality in Optometry 1 checklist. The process for cataract post-op, of course, is a little different to pre-ops because the patient's coming in from different places now. So the process is as follows. The surgeon removes the cataract, and the patient is discharged and given a list of local providers. So I'm hoping that everybody who's attended this evening will sign up to deliver this particular pathway, and your name will then appear on that list. The patient then makes a choice of where they have their cataract post-op done. Now, if you're already their regular optometrist, you've referred them for the pre-op, I think the overwhelming majority of patients would come back to you then for their post-op. Although technically, patients do have the right to choose. If you're not providing this particular pathway, your name won't be on the list, and then somebody else who may be present this evening, the patient will choose to go there for their post-op. I'm going to talk a bit on the next slide or the slide after about how that works in terms of dispensing spectacles to that patient when technically they're not your sight test patients. And I say your sort of in inverted commas because of course the patient has a choice to do what they want wherever they want. So the provider then completes the assessment on the EOS app. So that's exactly the example that we just saw on the video. Peter was literally walking through completing that post-op form. And you'll notice at the top of that form, it said the consultant name and address. You'd be surprised how many optometrists put their own name and their practice address in that box. So just remember, consultant does mean that the surgeon, and the address is the name and address of the hospital where the surgery took place, and that'll be on the discharge form from the hospital. Our job is then to follow that clinical protocol and make a decision on whether the outcome of surgery has been satisfactory or unsatisfactory. The overwhelming majority will be satisfactory, but there are some cases where there's some post-operative complications or a refractive surprise or unexplained reduced VA, and those will be marked as unsatisfactory. The system will then automatically send that audit report back to the surgical provider. So that all happens for you. But one key point here, which I will emphasize again in a moment, is if you find a post-operative complication like cystoid macular edema or steroid response or corneal decompensation or inflammation or whatever it may be, the audit report that we send for everybody isn't a referral, it's just an audit report. Whether it's a satisfactory audit report or an unsatisfactory audit report doesn't make any difference. You still need to create a new referral to the relevant speciality for that post-operative complication to be assessed. So if it was cystoid macular edema, you may choose to send an urgent referral to the Macular and Medical Retina Clinic. If it was corneal decompensation, you may choose to send an urgent referral to the corneal clinic or the external eye clinic, for example. But that's in addition to sending the audit report back. The good news is that the web app will automatically prompt you to create that referral at the point of choosing unsatisfactory outcome. So that's again, one less thing for you to have to do, but do remember to submit that additional referral. Here's the cataract post-op clinical protocol. Again, it'll look just slightly different when you see it, but it'll be 90% the same as this, if not more. It walks you through the history and symptoms. It walks you through the various initial tests, the parts of the anterior eye to look at, parts of the posterior eye to look at, and then a patient discussion at the end. And as with the pre-op, you have a post-op form here, and it just literally takes you through step by step. And we'll have a look at this form on the next slide, as we did with the pre-op form, just so that you're comfortable with filling in those different bits. So the name and address and date of birth, if the patient's already with your practice, then you won't need to complete any of that again. Date of procedure, consultant name and address. We've already touched on those things. So that's the treating surgeon and the hospital name and address. We undertake a refraction. Autorefractor is not acceptable, so you wouldn't just do an autorefractor and literally copy and paste that in here. It is a refraction and measuring the visual acuity. We measure the intraocular pressure, and you need to bear in mind that about 10% of the population are steroid responders, so the pressure is going to 25 or above. You then would undertake a slit lamp assessment. And again, you'll see here dilate where clinically indicated. So it's not sort of black and white, you must dilate everybody or you must not dilate anybody. If the eye is white and quiet and the visual acuity is as expected and the refractive target is as expected, patient's happy, patient's asymptomatic, and you've got a decent view of the macula to make sure nothing's going on, the argument is there much benefit clinically in dilating that patient? If you wanted to do gold standard care for every patient, then yes, you dilate all of them. But most of us, when we're working in this, let's call it an enhanced service role, you would take a view on whether or not dilation is clinically indicated. Let's have a look at some of the individual parts of the eye that we'd consider as part of a post-op assessment. First of all, wound healing. So when the surgeon makes the incision, the edges of that wound would naturally self-heal and ideally align with one another. You wouldn't want those to be out of alignment, so the edges are nice and smooth. You may sometimes see in section through that wound some very tiny metallic foreign bodies, especially if you're on high magnification. And that's pretty normal to see a few of those tiny metallic foreign bodies there from intraoperatively. You'd have a look at the cornea to make sure it's clear. We're not hoping for no decompensation and corneal edema. These patients would normally be quite symptomatic. We're having a look at the anterior chamber, looking for inflammation. And because of all that sort of sticky inflammatory material, then patients may develop posterior synecdoche. Again, these patients would tend to be symptomatic. They're not going to come in with a quiet white eye. They're going to usually tell you something's wrong. And seeing just one or two isolated cells, remember we are talking now 4 weeks post-surgery, the odd one or two cells in a quiet white eye is usually within normal limits. If there's much more than that, if the eye's red, if the patient's symptomatic, we're in a different category then altogether. So just the odd one or two isolated cells are less concerning. As far as the iris is concerned, when the instruments are going into the eye, they can chafe on the iris and they can cause a little bit of local trauma. So part of the iris may appear a little thinner where the surgery has taken place. The key thing is to make sure that the pupil is round and not distorted. PCO, posterior capsular opacification. A bit of PCO is pretty normal. I don't think you'll find many surgeons who would want to do a YAG capsulotomy within the first 6 months or so after surgery. Of course, there's exceptions. Perhaps if a patient has only one functioning eye and the PCO is quite marked, and then that's again maybe different. But generally speaking, a bit of PCO, we don't tend to get too excited about that. And of course, if you see any activity in the vitreous, if you're thinking about vitritis, endophthalmitis, that patient's going to be referred back to the hospital on a very urgent stroke emergency basis. A couple of other things to think about. Pain, so to differentiate between discomfort and pain, a painful red eye is more concerning than a painful white eye in most cases. Pain, depending on how severe it is, post-surgical, would normally be referred back. But just think about some patients, do have quite dry eyes, and they can misinterpret the symptoms of dry eyes for pain. Unexplained reduced VA is an interesting one. So you want to have a look at the refractive target. So that's the refractive error that the surgeon was aiming for, and compare that with the actual refractive error that you found. Also have a look at the expected VA, so the VA that the surgeon expected versus the actual VA that you've measured, and of course your pinhole acuity. If things aren't adding up, two good places to go looking are the macula and the cornea. As far as the macula is concerned, CMO can present anywhere from a few days to, well, it says here 4 weeks, but I'd suggest maybe even a bit longer than that. So you may well still be seeing that at the 4-week assessment. So it's worth considering that. Now, admittedly, if you have OCT, and by the way, OCT is not mandated on this pathway, but if you have OCT and you have somebody with unexplained reduced VA following cataract surgery, it can be very handy to put them on an OCT. Amsler is a much cheaper version, and it will give you some idea, of course, of what's going on with the macula. So do bear your trusty Amsler grid in mind if you have unexplained reduced VA. Do also bear in mind that some people are more susceptible to cystoid macular edema. So people with a compromised macula, so whether it's due to an epiretinal membrane or some vitreomacular traction, diabetic patients, they're a bit more prone to CMO. Remember also that a glaucoma patient who's taking prostaglandin analogues, because prostaglandins are part of the inflammatory cycle, as you may remember from the university days. So these patients technically are putting inflammatory mediators into their eyes to treat their glaucoma, if you look at it in that way. So if they're already saying to the eye, here's some inflammatory markers, it's not surprising that they're a bit more at risk of cystoid macular edema. And some surgeons do stop prostaglandin analogues several weeks before surgery. So just look out for it. If you do see a CMO patient, ask them about any other drops, any other diagnoses. And the last part of this form is we're asking the patient, from their perspective, are they happy? Are they satisfied? Are they dissatisfied or not really sure either way? The overwhelming majority will say satisfied, which is great. The dissatisfied ones, you'll find probably from the same experience that I've had, if there's some refractive surprise or they were myopic before in that eye and the patient's left them emmetropic and they're saying, well, I can't read anymore, they seem to forget the fact that they can actually now see through that eye thanks to having the cataract taken out. Yes, they may need spectacle correction, but sometimes people are dissatisfied for that reason. And neither, I've found, tends to be where there's comorbidity. So the cataract's out, but they've still got the AMD or the amblyopia, and they were expecting everything to go away having had the cataract surgery done. So just going back to that point about the audit report. So, sorry about that. If you have an unsatisfactory outcome, we still send the audit report. We send the audit report for everybody. But if you do find some unsatisfactory outcome, you have to create that separate referral to the appropriate subspecialty with an appropriate level of urgency. And I know I've said that a couple of times. I make no apology for it, because despite having made that clear a number of times, optometrists still forget to make that old referral. Just remember, the audit report is just for statistical purposes. It's not treated with any level of urgency. It is just statistical. Then going back to that point about dispensing, if the patient comes to you for their post-op assessment, that is what they've come to you for. They come for a post-op assessment. If the patient says to you, I would like to change my glasses and I would like to get them from you, that's fine. That's the patient's choice. But that's quite different to us doing a post-op assessment on, let's call it another optometrist patient. Let's say they've been with Joe Bloggs Opticians for the last 10 years. And we say, right, Mrs. Jones, I've done your post-op assessment. You do need some new glasses. Would you like to come with me and let's have a look at frames? That idea of actively dispensing to somebody else's patient, I'm just not convinced about the ethics of that. So I would very much let the patient lead in that respect. And if they do want to order specs from you, that's fine, but maybe just make a simple note to say, you know, patient elected to, or patient opted to order specs from our practice, something along those lines. I think you'll find most of these patients will be your own that you've referred for surgery. They've had the surgery, they've come back, and then you're dispensing them a spectacle. So I don't think this will become a significant problem, but I just wanted to plant the seed there. Just think about how it may appear to the other clinician. We're just being asked to do a post-op report. So hopefully that's clear to everybody, and hope you can see that there's nothing in there which is particularly challenging. These are things that we're comfortable doing using the slit lamp, which we do day in, day out. Okay, let's go on to glaucoma repeat readings. Excuse me. Again, this is like the cataract pre-op assessment. It's all about trying to reduce the false positive referrals. There's two aspects to it, as I mentioned. There's repeat pressures and there's repeat fields. Repeat pressures, you're using a contact anemometer rather than the MCT. Contact anemometry GAT is considered the gold standard. And repeat fields, if you've got something where perhaps the visual field test was unreliable, so the fixation was poor, your false positives, your false negatives were maybe more than about 30% or so, and you're just thinking, I'm not going to be able to put much weight on the reliability of these fields. Or a sort of spurious defect, and you just think, well, I'd like to repeat that just to see if that really is a defect, or if it's just perhaps the patient just needs a bit more practice at the test. We all see these patients day in, day out, so it's all very familiar to us. Training wise, again, this is core competency. You know, the CCG have made it clear that they want to commission pathways which are at core competency for optometrists. But we do acknowledge that some of us are not using contact anemometers on a regular basis. So you may well want some top-up training, and you have a couple of options there as well. So you have the WOPEC Glaucoma LOXU course, or we can provide training for those who request it. All of this is underpinned, once again, by a clinical protocol to support you with the types of questions to ask and the types of assessments to undertake. So we really try and, you know, sort of help you with this as much as possible. That's not to say that we're telling you, you know, you have to do X, Y, and Z. Please try and think of it more as some sort of support and sort of guidance, just steering you in a certain direction with your assessment. Ultimately, clinicians have the flexibility and to use their clinical judgment as they see fit. But I think to deviate significantly from a clinical protocol, you know, you'd have to have a good reason for that. So equipment-wise, unlike the first two pathways, there are a couple of extra bits and pieces that you'll need to deliver this pathway. The first one is some topical anaesthetic, which interestingly isn't required by the Quality in Optometry 1 checklist. And I don't think any patient's going to thank you if you don't put a topical anaesthetic in their eye before you do contact anemometry. You're going to need a contact applanation tonometer. GAT is preferable, and as I said, that's the gold standard, but Perkins is acceptable. You're going to want some disposable tonometer probes. I've just put the name of a few different ones. There's several different ones on the market, but those are just there as examples. I don't have any commercial interest in any of them. And the last thing that you may find helpful is some surgical tape. So if you're doing a repeat field and you think that a ptosis or a dermatochalasis is actually affecting the superior field, then you may want to tape those lids up using something like micropore tape so that you can get some more reliable visual field tests. I've literally just pulled this out of the Haag-Streit manual contact tonometer. We're all familiar with what we're looking at when we're doing contact tonometry in terms of the position of the probe on the cornea, in terms of left and right, up and down. And then, as you know, as you increase the force on the cornea, then the two rings get closer and closer, and you want it when they're just overlapping and the inner rings, the inner rims are touching on each other, which is what you can see in number 14 here. Whereas 15 and 16 and then 17 are too far either side, if that makes sense. So the criteria, or let's say the inclusion criteria for this particular pathway, based on intraocular pressure, it has to be between 24 and 31. If the pressure was more than 31, you'd probably be thinking about referring that patient on to the hospital on probably a reasonably urgent basis for various reasons. And it's unlikely that if you did contact tonometry on somebody with a pressure of 32 or more, that it's going to end up coming down to that magic number of 23 or less. And if it's 24, that's essentially, as you know, the start point based on NG81, NICE NG81, where they said anything over 23 is eligible essentially for an onward referral, depending on what's being commissioned in that area. So this pathway is more likely to give you a pressure which you don't need to refer on repeat when you're at the lower end of the scale. I mean, to my mind, 24 to 27 is probably the most chance of repeating it and getting it at 23 or less, assuming everything else is okay. Visual fields. Now, interestingly, I always thought of glaucoma repeat readings as it has to be a field defect which could possibly be due to glaucoma. But actually, this pathway is more flexible than that. It does talk about other pathology. So it gives you a bit more scope to use the pathway. But what you do require is something that's a bit suspicious, an unexplained defect. We've already talked about unreliable fields. Or it specifically says a significant defect measured on frequency doubling technology with no known cause. So for those of you who use FDT, this might also be relevant. Another thing that's quite interesting about this pathway is that when you do the repeat fields, it doesn't have to be full threshold fields. It may also be suprathreshold fields. I would suggest that full threshold fields would be your gold standard. And when I say full threshold, I don't mean that you can't use intelligent algorithms like CETAFAST and ZATA and so on. But I do think full threshold gives more information, your reliability indices, your probability values, and so on and so forth. So I would consider that over suprathreshold, but according to the pathway itself, you may use suprathreshold. What you can't use is FDT. So FDT can feed into this pathway, but when you're repeating the visual fields, it has to be on, let's call it a normal field screener, not using frequency doubling technology. And please don't take that the wrong way. I actually quite like frequency doubling technology. When I say it's not normal, I mean a conventional visual field analyzer. And this is something to be aware of. It has to be done on a different day to reduce the influence of fatigue. And now you may say to me, well, this is the first patient of the day. They've just woken up, they're not going to be tired. That may be the case, but it's pretty clear in the specification it has to be done on a different day. So please just bear that in mind if you're referring a patient onto this pathway. And, it's not for me to say for sure, but if you then manage to confirm an abnormal field defect as a result of this pathway, then those are the patients that more often than not will end up being referred on to the hospital. Not necessarily. The whole idea of the pathway is to see, is that field defect really there or not? If, for example, you had a patient with glaucomatous looking discs, a dense, obvious, marked, superior arcuate defect, I don't think it would be and a reliable field plot, let me just caveat it with that. I don't think it would be particularly appropriate to put them on this pathway when it's clear there's a reliable, marked field defect, because it's very unlikely to go away by just repeating it. So this is more for those kind of borderline cases where you just want to know, is this real or not? Get a good reliable field defect. There's the clinical protocol. As before, you'll see it has a pretty similar layout to the cataract pre and post-op. We walk you through the history and symptoms, the initial tests, and the anterior segment and measuring the IOP. So this is sort of 90% again of the actual protocol. You'll see we've adapted them slightly for these 4 commission pathways for you. So that will hopefully be helpful. So that's the end of the glaucoma repeat readings. And the next thing we're going to look at, in fact, the last of the 4 pathways, is medical retina. And medical retina is actually a less common one for the community, but I think a really helpful one. I think more and more optometrists are getting involved in this type of work. So as before, it's about reducing false positive referrals, but also using the pathway and the technology to help facilitate remote monitoring of patients and to reduce physical attendance at the hospital eye service. So this particular pathway is more multifaceted. It's more forward-looking and it's broader. But we're looking quite specifically at wet AMD and diabetic macular edema. We'll have a look at each of those individually. Once again, this is a core competency for optometrists, bearing in mind that the images that you capture that you would send on to the hospital eye service, these are likely wet AMD patients, they're likely diabetic macular edema patients. The skill here is actually capturing the image and actually attaching that to the referral. There is an element of interpretation as well, but you wouldn't probably be referring the patients onto this pathway unless it was pretty clear that something was wrong with them. So in terms of support, I think particularly for our colleagues who are just getting into OCT, just learning about OCT, it seems like such a big subject. And there are some resources out there that can help with that. Again, there's a WOPEC LOXU module on medical retina, and we can provide training to those who require it and request it. Again, it's all underpinned by a clinical protocol. So you see it's a pretty similar theme that runs throughout these 4 pathways. This one also requires a bit of extra kit, as you've probably worked out. So OCT, it's the only one of the 4 pathways with mandated OCT, and you need a fundus camera. So this is the only pathway of the 4 where you must have OCT and you must have a fundus camera to deliver the pathway. On the other ones, OCT is probably helpful for cataract post-op, but it is not mandated. It is not a requirement, okay? Here's the clinical protocol. And you'll see this one's a bit more involved than the other protocols we looked at. And again, it's been scaled down a little bit for this particular pathway, but it will give you some quite specific questions that you can ask about. So, for example, smoking history and social history, UV exposure, and these sorts of things, which are much more specific to maculopathy generally. It also talks about the types of OCT scans to do. We're all familiar with this. I've just put it in here for the sake of completion, just to show the picture. So as we all know, dry AMD, and in this case, geographic atrophy here, we can see here how the retinal profile dips right down into the macula because of the loss of these outer retinal layers. We can see all this reverse shadowing, where essentially the OCT is penetrating through the retina because we've lost all this pigmented material. And you can also see at the edge there a bit of drusen, which you can also see at the edge here. I know this is all familiar to us, so just really for the sake of completion. And comparing that with a wet AMD patient, where you can see the profile is really going completely the other way, because this time we've got something coming up here, choroidal neovascular membrane. You can see the hemorrhage in the subretinal space. You can see some intraretinal fluid as well. And this is clearly a case of wet AMD. Now you can see that having the fundus photo and the OCT really helps us in both of these cases. And that's why these pathways do mandate that you have both the OCT and the fundus camera. And just to show you where I've pulled that image from. This is the pathway, and the red brackets at the top show the part that we're going to be particularly involved in. So it's this macular assessment, having seen a patient with a suspected choroidal neovascular membrane, let's call it wet AMD. We take a history and symptoms, asking the relevant questions. And then for both eyes, not just the affected eye, of course, but both eyes, we're going to measure the visual acuity. We're going to have a good look at the posterior segment. We're going to take a photo, and we're going to do the relevant OCT scans. And then off the back of that, more often than not, the patient's going to end up on a fast track macular referral or a rapid access referral to the hospital. And in the unlikely event that something like this, having been scanned, turns out to be early AMD or nothing that requires treatment, and then you'd manage that slightly differently. But I think you'd all agree that if we're seeing this type of thing in a patient, it's very likely that they're going to be onward referred. So that, in a nutshell, is the wet maculopathy pathway. So it's probable stroke likely wet AMD coming in, and we're really confirming that and adding a lot of value to that onward referral by adding the fundus photo and the OCT images, so that the receiving clinician in the hospital can make an informed choice on how quickly they need to see this patient, and if they need to see them at all, and how soon then they'll require treatment. Moving on now to diabetic macular edema. As we know, macular edema is about, excuse me, fluid leakage. So we have exudate, which is protein. We have hemorrhage and general intraretinal fluid. So you can see all of that very nicely here on the OCT, some subretinal fluid. And again, the retinal profiles are very distorted, as you'd expect, with all this fluid. Just again to show where I got this, what seems to be a copywritten image from. So just to credit there, and please have a look at the American Academy website, an article about diabetic macular edema. And I suppose a similar pathway to the wet AMD pathway. So we see somebody at their site test, and we suspect diabetic macular edema, and we do something very similar: history and symptoms, both eyes, VA, good look at the back of the eye, photo, OCT scan. And off the back of that, it's very unlikely, I think if we see something like this, it's very unlikely that it's non-vision threatening condition, and we're sending them for diabetic eye screening program. It's an option. More often than not, it's going to be some sort of vision threatening pathology which we need to refer on. So if in doubt, it goes to the hospital. Because it's got the images, the hospital can then make a judgment as to whether or not this patient needs to be referred in and seen face-to-face by them, or indeed if they can continue in the community. So that really concludes the medical retina pathways. I've just got 2 final slides for you here. The first one is about contracting and payment. We need to be paid for what we're doing. So as things stand, in order to see patients on these pathways, you need to be signed up to the NHS-X ERS service. And we can give you the information as to how to sign up to that if you haven't done so already. The contract will actually be built into the EOS app that we were looking at the video of earlier. It'll literally come up and then you click to accept the contract, and then you'll be essentially ready to go. The EOS Clinical Handbook, which is not just the clinical protocols that we had a look at this evening, but there's some other operational policies that go around that, such as infection control and so on. That will also be available to you through the EOS app. So the app is sort of self-contained and has all the various resources that you need within it. To talk about billing, all of that happens automatically, so you don't need to concern yourself about complicated invoicing processes. And what happens is on the 6th day of each month, we will create a report for you of all the activity that you've undertaken in the previous month. It's important that if you start a visit within the EOS app, that you complete that visit. So say, for example, you create a visit for glaucoma repeat readings, but you don't actually complete that visit. So you maybe type in the repeat readings, but you don't finalize, you don't assign an outcome to that. As far as the system's concerned, that episode of care is still open and you wouldn't be paid for that. There's no real reason you keep it open, because you just see the patient and then you complete that episode of care contemporaneously, which is what would be expected. But just be aware it's completed visits which are paid. You then have self-billing invoice generated around the 15th working day of each month, and that leaves a few days to raise any queries before payment is made, give or take, at the end of the month. I've listed here the tariffs. So the pre and post-op are both the same at £35. The medical retina is a little more at 45 to acknowledge OCT and fundus imaging. And the glaucoma repeat readings, I think for the overwhelming majority of patients, they'll just need a first visit. If you happen to repeat, say, the IOP and it's 23, 24 and the fields are maybe not on a defect, you may occasionally bring a patient back to repeat those tests once more. But I wouldn't expect you to make it a habit of that. That would be more by exception. And the final slide is a reminder about the adoption payments, which I'm sure you will have all heard about by now. So we've been working with NCL ICS to agree what's described as a groundbreaking advancement in the electronic ERS service. So we've secured additional funding for primary care optometry over and above the GOS site test fee. And this has been going on now for the last month or so, in fact, that any referral that's submitted that meets a minimum best practice standard receives an adoption payment of £10. And the purpose of that £10 is to recognise the costs associated with having that technology and the time it takes you to export the fundus photo or the OCT data or the visual fields and attach it to the referral that you're generating. And just to make it very clear, the difference between sending a referral via ERS, which is what I'm talking about here with the adoption payment, which is quite different to any diagnostics that you take as part of the community service for the pathways that we've just been talking about. So you wouldn't claim for seeing a medical retina patient and then claim again for submitting that on the ERS because you've essentially already been funded for the OCT when you saw them within the service. So that's everything I was going to cover. In fact, not quite true. I've got some references here for you. So the NICE guidelines, 77 for cataract, 81 for glaucoma. You'll know all about these. There are some good resources on the College of Optometrists website in terms of guidance and their CMGs. And a lot of optometrists shy away from the Royal College website, but there's actually some really good resources there too. And I'd encourage you to have a look at that. It's not all sort of, you know, surgical and complex medical stuff. And there's some very interesting things, especially in the context of glaucoma. And there's a few other nice references. We wrote a referral in Optician magazine back in 2018, talking about how NG77 impacts cataract referrals. So that's there if it interests you. And we have some other training resources and the clinical protocols, which I've kind of touched on as we go through. And yeah, really just to thank you for your attention. I'm sorry, it's a bit of a monologue from me running through that, but I'm hoping I've given you an insight into the 4 different pathways from a clinician's perspective, as well as sort of from an operational perspective and what's required. And I think between us, we'll take questions. So I'll stop my screen share at that point and hand back to Owen. Thanks.
Yeah, thanks, Christian, for that. Yeah, before we go on to some more questions, I believe there's just some open ones that need to be answered regarding the presentation. Not sure if you can see those at the moment that people just put in the chat. Can I also just remind everyone if they could put their name and GOC number in the chat for the application for the CET, please, if you haven't already done so.
Yeah, thanks, Owen. I forgot to mention, actually, we have got it approved both for optometrists and dispensing opticians this evening. I'm mindful that some of the DOs in particular have struggled a bit to meet their minimum number of CET points for this cycle. So we made sure it was accredited for both. Were you asking me to answer the questions, Owen?
Yeah, there's 3 in there, I believe, that are clinical based for yourself that Dougie has asked us to have a look at, if that's okay.
Yeah, sure. So the first one is pressure of 24 to 31. So we're talking about the glaucoma repeat readings pathway. What if you use applanation routinely as I do? What are the IOP criteria then? Well, there's 2 different ways you can look at this. If you're happy to continue to do applanation tonometry free of charge, that's great. I'm sure that the CCG would be delighted to not pay you to see patients on the glaucoma repeat readings pathway. But I think if you're using it routinely, I don't really know how you're going to tease out those patients who would have had a raised IOP on non-contact tonometry. It's a fair question. I don't think it would be fair to pay you to repeat Goldmann on a patient with pressure of 30 or 29, 28, because it's very unlikely to come down to 23 when you repeat it. So the simple answer is that the pathway and the proof of concept document don't give you an option. It's very much the IOP is raised on non-contact tonometry. On a personal level, and I don't really want to say anything out of inappropriate, but if you had 24, 25 on Goldmann and you wanted to repeat contact tonometry, to my mind that's not entirely unreasonable, but I think we'll find out the answer to that because it's not covered in the document itself. So I'm sorry that's only half an answer. And the next one, but it's not part of the post-cataract pathway, I presume. So if OCT is needed due to CMO, does it become, okay. So the question is, if somebody on the post-op cataract pathway has reduced VA, and we think it may be due to cystoid macular edema, you're right in saying that OCT is not mandated. As I said at the time, it's helpful. If you're willing to do it, great. But it's only helpful, it's not mandated. As far as the medical retina pathway is concerned, that's actually diabetic macular edema. Well, the question's just disappeared, I'm afraid. Diabetic macular edema or wet AMD. So technically, cystoid macular edema doesn't fall under that pathway, according to the document. But again, I don't want to talk out of turn, but I can imagine that that type of pathway could develop in due course. But for simple post-op complications, is reduced, I'd go to your AMSLA if you're not happy to use your OCT or if you don't have an OCT. And it's either then a likely macular problem, which you're going to refer, or it's unexplained reduced VA post-op, which you're probably going to refer. So I hope that answers the question. I don't think that would come under the medical retina pathway as things stand. Next, is an Optomap scan acceptable instead of a fundus photo for medical retina? Well, that's another good question. I think we're all agreeing that it wouldn't be a substitute for OCT, but as well, I'm sure you know, if you've got an Optomap, it's using red and green laser to give artificial color. So I'm not convinced that that would be acceptable. I think that's something we probably have to check, because the consultant receiving it, I'm sure they'd appreciate knowing what's going on right out at the periphery, but I wonder how much detail it's going to give them of the macula and how true the color rendering is going to be. So that's another good question, which I think we can just get some clarification on if you wouldn't mind noting that, please, Owen. And a question here, so in that case, you'd be okay to charge patient if they want an OCT. I'm guessing that that's relating to the previous question about a post-op with cystoid macular edema. Well, if the patient wants an OCT, you're starting now to blur the lines between NHS-funded care and private care, and the patient shouldn't have to pay for any aspect of their cataract post-op assessment. So that's the bottom line. If you've got unexplained reduced VA, as I said, that's cause to refer on for further investigation. And if they've got suspected cystoid macular edema, same thing. I would be quite cautious about blurring those lines. So what you might want to say to the patient is, I've done your post-op, you haven't hit the VA markers, you know, that I was expecting. I think we need somebody else to have a look at you, so I'm going to offer to refer you on. Finished, post-op finished, and then if you wanted to do something completely separately to that, and you said, look, this is not part of the service, I can do an OCT scan for you, I would be very, very careful with that, just because those lines start to get blurred, and NHS care should be free at the point of access. So I hope I've answered that to your satisfaction, and I hope I got the right end of the stick on that.
Excellent. Thanks, Christian, for that. Obviously, as we just continue for the next few minutes, if anyone else has any questions, please just type them in the Q&A box and we'll try our best to answer those. I believe also, before we finish that, Prakash, the LOC chair, would like to say a few words. Not sure if you can unmute them, Christian, if that's okay.
Yeah, sure, I'll sort that out. There's just one other question. Sorry, Prakash, if you just bear with me for a sec. It says, please clarify the £10 EERS referral fee is not linked to doing images and is just for referral. That's not quite right. So the £10 adoption payment is that you've done those images and you're essentially being paid to attach those images to the referral. So it's a best practice referral, essentially. We're not just paying £10 for you to send a referral. So it has to have the relevant clinical information. So if it was an anterior eye problem, there'd be no point in you attaching an OCT scan. You know, if it's a back of eye problem, then yes, you know, photos, OCT scans, and so on. Let me just find Prakash.
Yeah, also, I think Dougie would like to answer part of that as well.
Christian, thank you very much. I know it was very detailed, but I think it was very necessary as well. So thanks for the insight. I think almost everybody here as optometrists were totally on your wavelength. I just want to say, as a new initiative, as chair of the LOC, that we're wholly supportive of anything that the NHS is trying out. And I know this is a pilot and it's a proof of concept, but the LOC is fully supportive to help the NHS reduce any stresses and strains at secondary care level, obviously without compromising our members. So I think this is definitely a way forward, and we look forward to working with you and Delia for the next 6 months. I think there will be a few bumps on the road. I can see that already. And I've got about 10 questions in my head, which I'd like to clarify. And this isn't the forum for that, but perhaps we can do that offline, just for the benefit of our members. But, you know, thank you for the time you've given, and thank you to all the members who are present for giving their time for this initiative, showing their commitment to helping the NHS in, you know, in innovation and in an innovative way. Thank you.
Thank you
Thanks.
for that. That's very kind. So just before we wrap up, any questions that have actually been put out there today will be actually sent out in a document in a full detailed email that will be sent to you in the next few days by myself. Delia, thank you very much for your presentation. Christian, thank you for your support on this. And yes, look forward to working with you all in due course.